The theme of my presentation today is focused on mechanics involved in utilizing segmented arch without brackets. I do not have any conflict of interest to disclose. The segmented arch technique was developed by Dr. Burstone in the 1950s. Perhaps the T-loop spring is one of the most famous appliances associated with this technique. However, it is not used widely anymore. Nevertheless, it does not necessarily mean that the segmented arch itself is obsolete. In bracket-free treatment, flowable resin is used to attach the wire directly over the teeth, while the conventional brackets and tubes are still used in the buccal segments for convenience. This idea was first published by Dr. Musilli in 2008. Note that two different wires, such as rectangular and round wires, are connected at the canine. Segmented arch means arch wire is disconnected so that whole arch is divided into segments. What is the reason for using a segmented arch? It is my contention that the inadvertent use of continuous arch wire may create more problems than it can solve. Once the brackets are bonded to the crowded teeth, the amount of activation of wire is determined based on the position of the bracket slots and cannot be altered, and the wire needs to be replaced with a stiffer one sequentially. Let's do a simple thought experiment. In this simple crowding case, for example, a wire is inserted and activated. Let's suppose ideal force level is 100 and it is activated to produce 200 of the force level, which is considered excessive. Therefore, the force magnitude seems too high with this wire. There are some solutions that can be considered in order to reduce the magnitude of force in this situation. These may include increasing the inner bracket distance, reducing the amount of activation, utilizing a more flexible material, or reducing the cross-sectional size of the wire. However, it is not feasible to increase the inner bracket distance or reduce the level of activation in continuous arch wire. The only remaining options are to reduce the stiffness of the wire by decreasing its modulus of elasticity, for example, by replacing the stainless steel with night tie or using a smaller cross-section of the wire. This means wire replacement is inevitable. So the wire was replaced with a more flexible one in order to ensure that the force magnitude remains within the optimal range. As the wire flattens out, the tooth approaches its final position. However, the force magnitude drops into the subthreshold level, where the tooth movement can hardly occur. Theoretically, it may not reach the final position unless force magnitude is restored with stiffer wire. The inner bracket distance will always be less than the mesiodistal width of the teeth, no matter how narrow brackets are used. Therefore, reducing the bracket width is not fully addressed this issue. This is the famous three-piece intrusion arch developed by Dr. Burstone, composed of separate anterior and posterior segment connected by a cantilever intrusion spring. Note that the inner bracket distance is significantly increased and the amount of activation of the spring is independent from the bracket position. The wire will have a uniform cross-section throughout the arch. Sometimes it is necessary to vary the force magnitude depending on the locations, such as lower force in the incisors and higher force in the buccal segment. It is statically indeterminate, meaning that it is very difficult for clinicians to accurately figure out the force system from deflected wire. What makes the situation worse is that inherent inconsistency of the continuous arch wire, potentially leading to the produce opposite direction of force and moments that are beyond the control of the operator. A leveling arch wire was used in this crowded case, and the teeth were aligned. This would be considered more a result of luck rather than expertise because the force system from a continuous arch wire is extremely complicated to analyze and makes the prediction of the tooth movement very difficult as well. If you are lucky, you may achieve a result like this, but if you're unlucky, although the teeth are leveled in straight line, you may end up with occlusal canting like this. Can we predict the force system of leveling arch wire? Well, yes, but very difficult. All of us in this room should have come across this article published back in 1974. It begins by stating that the force system from an appliance is relatively unknown and prediction of tooth movement is very difficult. Many graphs and tables are depicted to describe the force system. The message of this paper is that there are 6 geometries and the force system is changing in accordance with subtle change of angle between the wire and the brackets. Considering the complexity of even simplest 2-tooth segment, it is needless to mention the complexity of a continuous full arch wire. You may want to scan this QR code and download the Bender's Toolkit, and it'll calculate the actual force system for you. It properly works under Windows 10 Microsoft Excel 2017. Then, how can segmentation overcome this uncertainty or limitation of the force system of continuous arch? In this case, for example, the arch wire is placed only in between lateral and canine so that it creates 2-tooth segment. For those with strong academic need to know the absolute force system, Bender's Toolkit can be used here. But at least segmentation can help to decrease the level of uncertainty, making it easier to determine the relative force system by chair side. Note that the continuous leveling arch wire is placed only after major discrepancy is resolved to reduce the side effects. There are many unique benefits from the segmented arch applied to bracket-free technique. The bracket-free can do what bracket cannot do. This young lady presents with gingival hypertrophy, make it very difficult to bond the brackets, particularly on the upper laterals. Nevertheless, clinical crown is large enough to bond the wire, initial, and after the treatment. Multiple cross-section and variable modulus. In the traditional segmented arch, multiple wires are connected by special attachments such as double buccal tube or canine brackets with auxiliary vertical tube. On the other hand, in the bracket-free, the entire clinical crown serves as an attachment. Various wires are used to apply customized variable forces. It is not a common practice for me, but in this particular patient, in the upper canine, there is a night-high coil spring, an elastic chain on the resin button, and 2 wires are bonded at 1 tooth. In this patient, flexible wire is used for incisor leveling and stiffer wire is used for root movement of the canine. Minimal wire changes. To replace the wire, resin dome is replaced by high-speed burr. Once you get used to it, it is not quite difficult to replace the wire. However, it is tedious and time-consuming. Therefore, instead of replacing the wire, augmented force systems are used. Augmented reality allows for an enhanced visual experience by displaying the desired path on the head-up display like this. The force can also be augmented to provide enhanced level. The upper canine is leaning distally and the root is leaning forward in this patient. A flexible leveling arch wire by itself will not provide sufficient moment to move the roots of the canine distally. Therefore, the moment on the canine is augmented by additional beta titanium wire. The green color in this diagram represents the deactivated shape, and blue activation force is applied to the spring to activate. The red arrows are deactivation force system on the teeth. Large inner bracket distance allows for large enough moments accompanied with very small amount of vertical forces. In this particular case, a vertical force erupts the canine and intrudes the molar to close the bite, which are beneficial for this patient. While the major tooth movement has been accomplished using augmented force, the minor tooth movement is performed by existing leveling arch wire, which helps to maintain the integrity of the arch form. The remaining space was closed by usual manner. This patient presents with severe crowding. Upper dental midline is deviated to the right side as well. Initial view. The upper incisor and mid-palatal raphe are deviated to the right side and right lateral is palatally blocked out. However, the PA head plate demonstrates no apical base discrepancy, which means the nature of this midline problem is purely dental aversion. The bicuspids were extracted and space was regained for labial traction of the lateral. After labial movement, X-ray shows the root of the upper right lateral and centrals are touching each other. A small piece of straight night-tie wire is added over the pre-existing leveling arch wire for force augmentation. The wire is bonded on the lateral first, and a couple is applied. The wire is elastically bent into a segment of circle and then it is fixed on the central. As the wire deactivates, the force system acting on the teeth are equal and opposite to the applied force system as predicted as red arrows. If you'd like to determine the absolute value of the force system, you may want to use the Bender's Tool kit, which you have been already downloaded. The result after 2 months. It seems there isn't much difference in these side-by-side slide intraoral photos. But X-ray shows that roots have been aligned parallel. Note that the inner bracket distance has not been altered during the significant friction between resin and the added wire. The augmented night-tie wire was removed and remaining space was closed after the treatment. This patient presents with severe crowding in the lower anterior segment. The labial position of the incisor was extracted and leveled. To remove the black triangle, once again, straight wire segment was used. And activation to converge the roots, which is the opposite direction to the previous case. After the root was converged, the incisal edge was trimmed before and after the root movement. This adult patient has her primary teeth retained due to congenital missing of the premolar. Lower lateral incisor is rotated and some space is required. Note that the wire is cut in between the lateral and the canine to avoid side effects. The lower dental midline is needed to be shifted to the right side. A straight night-tie wire was bonded on the lateral and activated. The deactivation force diagram shows a large moment on the lateral as well as horizontal force on the incisor and primary molar. In most cases, prolonged retained primary teeth are ankylosed, so that serves as a good anchorage. This spring not only rotates the incisor, but the lateral force is beneficial for midline correction as well. I must say that Dr. Engel designed this spring back in the late 1800s. As demonstrated in the previous case, if the wire were not cut, inadvertent leveling by continuous arch can result in a skewing of the arch like this. In this case, a small segment of straight wire is used in ribbon-wise direction to reduce the curvature of the arch. It would be very difficult to modify the arch form with the flexible continuous arch wire alone. Perhaps an open coil spring is one of the most frequently used appliances in case of space inadequacy. However, an open coil spring has a certain limitation. Theoretically, the open coil spring can be compressed like this, but it is unlikely to happen in the real life. Instead of compression, if the open coil spring is loaded beyond the critical point, it can cause a spring to fail by bending out of shape, like this. This phenomenon is known as buckling, which is considered a catastrophic failure of the structure in engineering. Therefore, leveling should be done first, and relatively rigid arch wire should be inserted prior to applying the open coil spring like this. Note that the rigid arch wire is inserted in the buckle segment. This patient presents with generalized spacing, and there are upper lateral missing. Beta titanium wire was used to open up the space instead of an open coil spring. Technically, using open coil spring in the bracket-free seems very difficult, and I have not even tried it. Replacing the flexible wire is not necessary because the arch form is not affected by this spring. This spring is so simple that it produces equal and opposite single forces only at the level of the crown of each teeth, therefore resulting in uncontrolled tipping, as you can see here. Once again, small segment of straight rectangular niti was used over the flexible wire for root axis correction. After the treatment, the typical treatment sequence for this case would be leveling the arch except for the lateral. This would be followed by the use of an open coil spring with a rigid wire and then a niti overlay on the lateral. The purpose of this extra step is to preserve the arch form. A single continuous flexible leveling arch wire may distort the arch form. The bracket-free technique can simplify this procedure. Level the arch except for the lateral incisor, and space is regained. A stiffer wire is bonded to stabilize the adjacent teeth like this. This segment of stiff wire is preventing arch skewing and maintain the arch form. Perhaps one of the most challenging procedures in the edgewise bracket system is the application of continuous light torque for third order root movement. This patient is complaining of excessive lingual inclination of the upper incisor. She not only has a lingual version of the incisors, but lacks horizontal overjet. A leveling arch wire was placed, and an incisor root spring made from reverse curved niti was added. The first step is to place the reversed curved niti wire on the incisor like this manner and fix with resin. In the second step, a downward force is applied to the distal free end of the spring, and it is ligated over the brackets. The wire is not inserted into the bracket slot to avoid unnecessary moment. The deactivation force system is depicted in red, which is effectively applied in large moment to incisors with vertical forces. Note that the inner bracket distance is very large. After the root movement, in this case, vertical forces are not harm at all, but rather beneficial for this patient to increase the vertical overbite. Here is the comparison between before and after the treatment. This patient presents with blocked out lateral on the palate. Space was regained and lateral is moved labially. As expected, the root remains in the palatal side. Root spring was fabricated using beta titanium and activated. In this case, a large moment is produced on the lateral incisor at the expense of unwanted vertical forces. Perhaps the inner bracket distance between these two teeth or across the arch is the largest possible in the oral cavity. Therefore, effective light torque of 800 gram millimeter was applied continuously without any other side effects. After the treatment, for complete elimination of unwanted side effects, the flexible full arch wire is never used. A leveling arch was inserted to correct the rotation of the incisors. Although the incisors were rotated correctly, the anterior segment became flat due to the inevitable and unwanted labiolingual forces on adjacent teeth. In this similar case, the centrals are severely rotated. A segment of rectangular straight night tie wire was bonded in a ribbon-wise direction to rotate only the incisors so that no side effects are produced on adjacent teeth. Note that the wire was extended on the right side to allow room for wire to slide during rotation. The arch form is maintained during the rotation of the incisors. In this patient, it can be observed that not only rotation of the incisor is necessary, but also labial version of the lateral incisor is needed. Therefore, the wire is extended to the lateral to produce the labial forces to the lateral incisors. A segment of straight wire was placed in ribbon-wise direction. The central incisor was rotated and lateral incisor were moved to the labial side as predicted. A full arch wire is placed for detailing. The leveling arch wire is used only after the major discrepancies are resolved. Initial inadvertent continuous arch wire leveling might cause unpredictable side effects. To slide or not to slide. You may want to experiment by putting some flowable resin directly over a wire. You may notice that the friction is quite high when attempting to slide the cured resin ball along the wire. In this case, due to the tensile frictional force, the incisor can hardly derotate unless the wire slides inside the resin. Therefore, the wire was placed on the lingual side not only to derotate the incisors, but also produce compressive force to open up the space by friction. Once again, a continuous leveling arch wire was used after the segmental leveling. To make it frictionless, water-soluble tube are used before applying the resin. I am certainly not saying that there's no friction at all, like a loop mechanics, but the tube dissolves instantly when in contact with saliva and creates a gap between the wire and the resin dome, similar to the undersized wire in a bracket slot. Where infinite friction is required, a small V-band can be incorporated inside the resin dome to prevent any sliding of the wire. Infinite friction allows for the elimination of rope tie in anterior segment, simplifying the treatment process. Let's flash back to the previous case. On the left central incisor, the resin was placed directly over the wire so that the friction is very high, while on the right side, soluble paste was coated to allow for sliding of the wire. Therefore, inner bracket distance can be increased as incisors derotates. It is aesthetic and comfort. Above all, one of my favorite features is being free from the risk of decalcification like this. I do not use brackets in the anterior segment for all of my patients. The bracket-free orthodontic is a very nice tool to apply segmented arch principle and provides excellent patient comfort and aesthetics. Thank you very much.